So the next couple of talks are actually focused on pulmonary hypertension, and the first one is actually a symposium sponsored by Janssen. So the first section of this is really to look at how do you suspect a patient with dyspnea. So if you have a patient with unclear causes of dyspnea, how can you make sure it's cardiac, pulmonary, or maybe it's both? And these are some very important clinical clues. This is my QR code. If you want a copy of the slides, I'm very happy to provide. So unexplained dyspnea, is it a rare problem? Actually, it's not. And one of the things that we have to remember, you see the picture in the background? What is this animal? This is a zebra, right? But if you hear hooves outside, you're more likely to think of a horse than a zebra. So in a rare disease, you have to think of these things because they are important, because they may be a lethal disorder as well. So first of all, what is pulmonary hypertension? It's not a simple blood pressure issue. And it's becoming more and more common. It strikes younger and middle-aged people, and it is not really rare, it's just undiagnosed in the clinical practice. So it's simply misdiagnosed, and you look at data from all over the world, you find that the commonest cause actually is idiopathic, followed by connective tissue disease, and then in the region I think we have congenital heart disease is very common. So what's the problem in pulmonary hypertension? It is this: the remodeling of the blood vessel makes them stiff and thick, and they are, instead of having small thin-walled vessels, they become arterialized, and the right ventricle fails. As you know, the right ventricle is supposed to be a small, thin-walled vessel that has a pressure of around 20 to 25 millimeters of mercury. It's not designed to sustain higher pressures, and over time it fails very quickly. This is the pathology of this, and you see from a thin-walled vessel with a single cell endothelium, massive thickening, massive fibrosis, massive hypertrophy. It's very improbable that the right ventricle can survive this persistent degree. Now, the problem, of course, is that all the patients come to you late. Obviously, when the patient has lower limb edema and an RV gallop and JVP, that's a patient who needs a transplant, right? We need to catch the patients at these stages because they still have symptoms, but the symptoms are being mislabeled as something else. So what are the groups? There are group 1, which is pulmonary arterial hypertension, group 2, which is heart failure or left-sided diseases, group 3 is lung disease, group 4 is chronic thromboembolism, and group 5 are mixed or complicated disorders. So the vascular remodeling and in situ thrombosis is a continuous process. It's progressive. It doesn't just stop at one point. This isn't like COVID, which causes inflammation and it goes away. It's a progressive vasculopathy causing increased pulmonary vascular resistance and right ventricular dysfunction. When this happens, RV remodeling is much more aggressive than LV remodeling. Remember, patients can have hypertension for decades before they develop heart failure. The RV cannot sustain this for more than a few months or years at a time. It causes RV ischemia, causes arrhythmias. Atrial flutter is very poorly tolerated in these patients. They go to atrial flutter, they collapse, and then they have RV dilatation and failure. So it's like LV dysfunction, but a lot worse. So some of you may be familiar with this paper. This is the UAE Pulmonary Hypertension Registry. We published this back in 2023. And without looking at all the details, here's a summary. Very late referral. People were referring, doctors were referring to us extremely late. Functional class 3 and 4. And very high BNP, very high pulmonary vascular resistance, low cardiac output, mostly females. Over 70% of the patients are females, ages between 40 to 45. So these are very sick young patients who are neglected by the healthcare system. Severe disease. I don't know if you can see the numbers here. These patients had extremely poor RV function, massively dilated right atriums, and this is the survival. So without treatment, the survival will be very bad. So we have actually a 7-year survival of around 25%. And in patients with connective tissue disease, which is 2 diseases in one, so this is patients with rheumatoid or scleroderma, the survival is even worse. It's 37% less. Now, what was the biggest problem we realized when these patients were being referred? Were they being given treatment? Yes, they were. What were the treatments being given? Low-dose sildenafil, monotherapy. This is contraindicated in the guidelines, literally contraindicated here. In the majority of patients, they were all referred on low-dose sildenafil. And of course, because we have the expertise and we follow the guidelines, 90% of the patients then became on dual combination therapy. Why is low-dose sildenafil contraindicated? It increases mortality. Increases mortality. I'm going to say it one more time. Low-dose sildenafil doesn't help any patient. It increases mortality. It fails to treat the problem. So Why do people have, in the clinical practice, some difficulty making the diagnosis? Many smart doctors, cardiologists, pulmonologists, internists miss this. Well, dyspnea is quite common. It has many causes. I will agree with you that COPD, interstitial lung disease, thromboembolism, and heart failure are more common as causes of dyspnea than pulmonary hypertension and RV dysfunction. Yes, but we cannot ignore the most lethal differential diagnosis that's not mentioned here. So when you look about this, the symptoms are exertional dyspnea, progressive dyspnea, inability to do simple exercise, and of course signs of right-sided heart failure. That's abdominal distension, lower limb edema, right? So you don't expect the lungs to have crackles. Actually, the lungs will be clear. It's the right ventricle that's affected, so it's the abdomen that's going to be the target. Next, you will have exertional chest pain. Why do these people have angina? The right ventricle is anterior to the left main coronary artery and will compress the left main coronary artery, resulting in dynamic anginal symptoms. Many of these patients get a left heart cath, coronaries are normal, they still come back with the same problem. Right heart cath is needed. And of course, recurrent laryngeal compression, and sometimes they will have physical findings. Now, what's the most obvious physical finding is cyanosis. If you have cyanosis, you have a cardiopulmonary disease, right? It can't be just the lung. It must be the right ventricle or the low cardiac output. And unfortunately, many of us don't even own a stethoscope. I don't even carry a stethoscope in the clinic. I depend on echo. I'll admit that. But the reality is, we really have to look at these physical findings. They're not subtle in these patients. And of course, if you look at things like clubbing and Eisenmenger syndrome, you'll have very loud murmurs. These things really can't be missed. So overall, the most common symptom is shortness of breath that progresses with exercise. But I told you the average age is 40 years old. So why would a 40-year-old have exertional dyspnea, right? Does anemia cause exertional dyspnea? No. This patient doesn't have heart failure, ejection fraction is normal. Tamam? Does COPD cause exertional dyspnea? It does not. It does not. They're wheezing or coughing. If they're not, it's another problem. And then fatigue, and then lower limb edema, and then chest pain. And then finally, as the symptom gets worse and worse, fainting. Why do these people faint? Low cardiac output due to poor RV function. This is a very poor prognostic sign and changes the patient to functional class 3 or 4. So, from the uncommon to the common, dyspnea is the biggest thread and we can't ignore it. So if you look at dyspnea in young patients, especially young women, anemia is often quoted as a cause. That is ridiculous, right? It cannot possibly cause this symptom. Also, we forget that the patient has a heart, and the heart actually can have either congenital heart disease or pulmonary hypertension. And if the LV isn't the problem, please look at the RV or do a bubble echo and look for congenital heart disease. And of course, lung disease is intermittent. Nobody is wheezing all the time. So if they're not wheezing and they're short of breath, it must be pulmonary hypertension. That's really a very simple thing. So in a young patient, why would they get shortness of breath, fatigue, weakness, angina, and syncope? It's a cardiopulmonary syndrome, not a pulmonary syndrome. And of course, worldwide, the diagnosis is delayed 2 to 3 years. So please remember this or take a picture of it. This is how we save lives. Red flags: fatigue, dyspnea, and dizziness. Late symptoms are chest pain, ascites, lower limb edema, heart failure. And as an electrophysiologist, I also see these patients: syncope and arrhythmias. Don't forget the structure. Don't forget the right ventricle. And of course, cough is a common enough symptom, but it's a fooler. So, for the cardiologists in the room, we cannot afford to miss the right ventricle. It is the most neglected and unreported in echo. Come on, guys, be honest. I know when it's busy, we get the ejection fraction, we report the tricuspid valve, and we go. Actually, the guideline requires the following. You must measure the right ventricle. You look for eccentricity index, which is D-shaped septum. You look for a dilated pulmonary artery. You look for the IVC or right atrium. And you must look at the pulmonary early diastolic, the pulmonary regurgitant velocity, or the RVOT acceleration time. Any of these equal pulmonary hypertension. Any of them, any one of them, even if the TR velocity is not elevated. So remember, zebra is an uncommon animal, but this is a dangerous disease and we have to think about this diagnosis. So, what we want to talk about is how to detect these patients. There are some high-risk groups. So if I'm a cardiologist, I get a referral from my friend, the liver doctor, portal hypertension. 50% of these people have pulmonary hypertension. Let's focus on the RV. I get a referral from the rheumatologist, connective tissue disease. Almost 30% of people have pulmonary hypertension if you have a rheumatological condition. It doesn't matter if it's rheumatoid, scleroderma, lupus, or mixed. This is a very high-risk group. HIV patients, 20% of those have pulmonary hypertension. And if you have a family member of a patient with pulmonary hypertension, the mother tells you, I have pulmonary hypertension, my grandmother died of pulmonary hypertension, the kid's gonna have pulmonary hypertension. This is really important. We cannot afford to miss any of these high-risk groups. If they're high risk, a detailed echo is mandatory. So consider pulmonary hypertension in exertional dyspnea, any patient with syncope and angina and dyspnea in the absence of signs or risk factors for cardiovascular or respiratory disease. If they don't have coronary artery disease and they don't have COPD, why are they having these symptoms? You have to think of cardiopulmonary, which is pulmonary hypertension. So the ventricle remodeling is trying to avoid it. This is one of the problems. If you diagnose the patients early, the mortality is greater. This is the problem. The more you delay, this is just diagnosis, not treatment. The mortality increases by 50%, and by 6 years, double. So we can't afford to miss it. This is why we're having these discussions. Now, what do you do if you suspect a patient with pulmonary hypertension? You refer to the pulmonary hypertension expert. This should not be managed in any place except pulmonary hypertension expertise. You have to, because there's so many tests that we have to do in order to detect and treat properly. So, suspect, fast track. And the word fast track is right on the side here, i.e., don't send a normal referral, send a WhatsApp, give us a call, we'll see the patient. As a center of excellence, we are required to see the patients as soon as possible. We don't wait for referrals, we expedite and we fast track. So what's wrong with this picture? You remember these x-rays? Okay, what's this? You call it a 3 sign. Why is this enlarged? The pulmonary artery is bigger than the aorta. So what's wrong with the lungs? They're oligemic. There's no pleural effusion here. This is shortness of breath because of a massive pulmonary artery. We used to see this in patients with mitral stenosis. We now see this in patients with pulmonary hypertension. What about this ECG? This patient was taken to the cath lab as an inferior wall ACS. Right axis deviation. The first thing you do is calculate the axis. See? Negative in AVL, positive in AVF. Right axis deviation. This is not ischemia. This right bundle branch block is due to RV strain. Now, what about NT-proBNP? Do we check NT-proBNP in the outpatient setting? We have to. It is the single most powerful test for dyspnea that you can make a diagnosis. When the NT-proBNP goes up, it is parallel to the functional class. And when the NT-proBNP goes up, it is parallel to the pulmonary vascular resistance. You are predicting the results of right heart cath with a blood test. So we have to do NT-proBNP in all patients with dyspnea. Pulmonary patients, internal medicine patients, diabetes patients. If the word dyspnea comes up, NT-proBNP is important. Now, baseline NT-proBNP is also very important. If it's more than 150, the survival is only 50%. If it's less than 150, it's 80%. And if you treat the patient and you correct it so the BNP remains low, the survival is almost 100%. But if you leave it to increase and increase, mortality within 3 years is 80%. So it's prognostic, it's diagnostic, it responds to treatment. We have to do this test. We have to, universally. What else do we need to look at? When I see the patient in the center, what do? We're looking at signs of heart failure. We're looking at syncope. We do a 6-minute walk test every single visit for every single patient. We look at their echo liberally. What are we looking at the echo? Right atrial area. TAP-C divided by the pulmonary artery pressure. Any pericardial effusion in a pulmonary hypertension patient is a high-risk marker. Pericardial effusion here is not benign. It indicates severe RV dysfunction. And only no pericardial effusion is accepted, some cardiac MRI features, but of course the king of all of this is hemodynamics. So the fast track is to look at the tests. Now, do cardiologists order pulmonary function tests? We should. Well, at least the pulmonologist should order the pulmonary function test. What's the biggest clue in the PFT? DLCO. Less than 70% means the vascular resistance is so high you cannot transfer oxygen. Very simple. And if it's less than 45%, it's almost certainly pulmonary hypertension. And this is key. So when you look at the DLCO, it tells you that the patient probably has pulmonary vascular disease. What about cardiac MRI? Cardiac MRI can very easily look at the right ventricle in 3D, tell you if there's delayed enhancement or scarring, and it can look at the pulmonary blood flow. It is not an easy test. What about the ventilation perfusion scan? Doctor, why are we doing VQ scan? It's obsolete in the era of CT pulmonary angiogram because it detects this. These are small distal peripheral obstructions that will be reported on a CT scan as what? No pulmonary embolism, because the CT scan is only looking at the proximal arteries. It doesn't see the distal vessels. So standard of care is ventilation perfusion scan, not CT pulmonary angiogram. That's what we need to do. And of course, you have to learn to look at the CT with your radiologist, look at the mediastinum for evidence of adenopathy. There are many different causes, but I think one of the biggest clues you have is this. How big is the pulmonary artery? It is bigger than the aorta. That is not normal. So in any CT scan, whether it's ordered by a pulmonologist or for CTPE, if this is enlarged, this is pulmonary hypertension. You have to ask the radiologist to always report this number. It's absolutely mandatory. So on the CT angiogram, you can also see the ventricular dilatation, so this is fairly clear, and you can also see the amount of scarring on the lungs. On the echo, let's remember that pulmonary hypertension is not TR velocity. TR velocity is not enough. It is a mistake to report only TR velocity, right? Why? Because say you don't get the correct envelope. Maybe it's 2.5, right? Maybe it's 4, maybe it's not. You can't risk the patient's life based on an envelope. You can look at all of these other structures. So big IVC, big right atrium, big pulmonary artery, dilated RV, eccentric ventricle, and the notching on the PW. These are essential things to be reported in a dyspnea patient. So what it actually tells us is even if the pressure is reported, the TR velocity is low, but you have any of the other features you saw on the previous page, still right heart cath may be indicated. Still, even if the TR velocity is not elevated. So let's remember that. ESC guidelines. Do we follow the guidelines in all matters of cardiology? And yes, we do. This is one guideline we can't miss. Look at all of this. These 12 things have to be reported on every single echo and every patient with dyspnea. I know it means a lot of work, but this is a standard echo. Look at these numbers. It's not just TR velocity anymore. And even as I said, if the TR velocity is not elevated, less than 2.8, you have any of these dilated chambers, echo leads to right heart cath. That's how it goes. So fast track is right heart cath. I spend Thursday all day doing 3 or 4 right heart caths. Dr. Muhammad in the same time does 7 angioplasties. I'm just slow, right? He's just fast. But the key point is fidelity of measurements, accuracy of measurements, right? We continuously keep recalibrating. There's 4 of us in the room. Do you see this? 4 of us. And we're not doing a PCI. We're just doing measurements. And you see how difficult this is. When you take a deep breath in, the pressure drops. And we're talking about measurements of within 5 to 10 millimeters of mercury. They make a huge difference to the outcome. We also have to give nitric oxide or inhaled iloprost. We do oxygen challenges. We do exercise, vasoactivity. Right heart cath has to be performed in experienced centers with complete sets of hemodynamics. This is how we characterize the patient. Pulmonary artery pressure above 20, wedge less than 15, PVR more than 2. Diagnosis is a must, not an option. Do not start treatment without right heart cath. Why? Because low-dose sildenafil increases mortality. You cannot use it. Okay, you're not helping the patient. So when you do a right heart cath, and Dr. Muhammad will tell you, I spend another 20 minutes outside the room with the technician, wasting time doing calculations. But seriously, this is what we do. These are all the measurements: cardiac output, mixed venous, and pulmonary vascular resistance, capacitance, cardiac index. This is minimum. There's more because we do it again with exercise. We do it again with nitric oxide. It's like doing 3 cardiac caths in the same setting. So improving earlier diagnosis will save lives. So despite advancements in treatment, and in the UAE, we're very fortunate to have every treatment in the world. Everything is available, right? Delays make patients die. Making the diagnosis and systemically evaluating patients with dyspnea, screening the high-risk groups, looking at the details with clinical characteristics, a framework for diagnosis, and specialized PH centers to rapidly assess patients, make the decisions, and provide support for patients and families and medication. Thank you. So any questions on this particular section? So this is focused more on the diagnosis, early diagnosis, and referral. And I can assure you, and many of you know this, if you ask for a patient pulmonary hypertension, we're seeing the patient within a few days, right? This is the reason, because ultimately all of the patients have been referred so late, we can't even afford in the outpatient setting. Any questions?
Just to compliment you, Dr. Hani, I think I worked before when I was in the UK in the specialized pulmonary hypertension center, with Jerry Coughlin, if you know him. So he was really very very passionate about pulmonary hypertension. But I think you are maybe more passionate than him about pulmonary hypertension, and you spend your right heart catheter is definitely the best I have seen. So not everyone should do, I think, right heart catheter. I used to do it, but to be honest with you, it took like 15-20 minutes without good measurements, and I don't think we'll get this information you're getting. So I suggest really every patient with suspected pulmonary hypertension should really be referred to you for detailed study, and the patient should be given the best treatment, the best diagnosis, of course, the correct diagnosis, and appropriate treatment, not like random quick right heart cath. This is my opinion.
Thank you very much, Dr. Mohammed. And I have to appreciate the support of the leadership in MediClinic and also my friends in the unit, because they've given me the time and space to actually do that. I mean, it's in a busy cath lab, and we do have to compete for time. You know, everybody's been very generous about giving me this time as well. So the next talk actually is going to be about more on the treatment algorithm. If I can have the slides, please. It's also about pulmonary hypertension. We tried to batch it together so, you know, to capture your attention. So I'm just going to describe to you the the pulmonary hypertension guidelines. So this is something I'm incredibly proud of, and incredibly proud of my friends and colleagues who supported this big work. This is 10 years of pulmonary hypertension in this country, and this is something we celebrated in our hospital on February 23rd. We had an international speaker. She's one of the writers of the US guidelines, as well as some friends, and these are my colleagues from the pharmacy. This is, of course, Dr. Muhammad, and the pharmacy team that supports us, and also my administrative team that also supports us. What's missing here is the technicians and the nurses who also help us in the cath lab. So you've already seen this. One of the things I wanted to highlight is that we make the point that this is a lethal disease. I want to make sure that everybody understands that without treatment, this is 30% mortality within 1 year. There is now no cancer in 2025 that can claim this horrible outcome, okay? It is hidden, it's progressive, it's deadly, and it's a misnomer. When you say pulmonary hypertension, people assume that you can treat it with sildenafil or amlodipine. These are the big mistakes. So tragically, these are young females after their first delivery, young mothers who die, and this is a very sad and tragic thing. We've seen a couple of patients recently. We really want to avoid this problem, and diagnosis is the first and greatest challenge, and therapy access is also the same. So I won't bother you with the same slides, but one thing to remember, with RV failure, death will occur within 3 years because of mortality is 30% in the first year. By the second year, it's 60%. By the third year, it's 90%. We really need to avoid that and suspect, detect, confirm by right heart cath, characterize, all of these things get done at the center so we can do it, as Dr. Muhammad said, very accurately. So I had the pleasure of working with these two brilliant gentlemen, President of the Emirates Thoracic Society, Dr. Ashraf Zahabi. Some of you might know him. He's at the military hospital. He's a very senior consultant pulmonologist. And my good friend, Dr. Muhammad Badr, who was the past president of the PH working group. So we worked on this for almost 10 years. And we looked at different things. What are the barriers to treatment? Diagnosis. Sometimes when internists order an echo, it's rejected. When a pulmonologist orders a BMP, it's rejected. This is an insurance problem and should go away, right? Simple tests, right? And also insurance was not only rejecting tests, but also rejecting right heart caths and rejecting medications. So we decided the only way forward is to do this. We write a guideline that belongs to the UAE, and therefore this will be adopted by the entire network, whether it's physicians, regulators, or insurance. This is the only way forward, consensus from guidelines. So unfortunately, Dr. Abdullah Shahab is not here. He's also the lead on the steering committee with the head of the Emirates Rheumatology Society. And this is actually the only comprehensive multi-society pulmonary hypertension guideline in the entire Middle East. The Saudis have one, but it's only from their group. This is a multi-society guideline. And this is the three societies: Emirates Thoracic Society, Emirates Cardiac Society, Emirates Rheumatology Society. So this is a unique work that took us almost a year and a half, probably even 2 years. 46 UAE experts and authors, right? 10 chapters. This is a work that hopefully will be continued and will have updates and reviews. If you're in the room, if I haven't mentioned your name, Dr. Harari also is one of our steering committee and one of our authors. And I think this is something that we should be very proud of. We have been very inclusive in trying to get as many specialties in this as possible. So this has now been published in the new Emirates Medical Journal. As you know, Professor Abdullah Shahab is the chief journal editor, and he gave us a lot of space in this. He wrote a very nice editorial explaining why we did this. And I also tried to summarize the rationale and design. And I mentioned in the first sentence, it is a lethal progressive cardiopulmonary disorder that strikes young adults and is a misnomer. We cannot take this disease lightly. So if you want to download the whole thing, that's the website. If you want to take a picture of it, it's benthamscience.com, and the issue is 1200, 12710, right? So you can download the whole thing. It's a special thematic issue. So the entire 11, 12 chapters is in one issue for people to review. I won't go through every single one of them, but it covers every single aspect of PH, and it is localized to the UAE. We talked about genetic testing, we talked about patient support programs, we talked about access issues, we talked about restriction of physicians. Everything is here, clinical and also administrative and regulatory. So one of the things I also wanted to show is every time I give this lecture at a meeting, we get more referrals. It's not because the referrals aren't there. Is because we're reminding doctors of a rare disease. It pops up in the top of the mind, and 2 or 3 days later, you see a patient, you recognize it. So it's simply that education increases the amount of referral and treatment. And that's one of the key components of keeping this message alive. And I go to every single meeting. Believe me, I insert myself like a cancer in the hematology meetings, in the rheumatology meetings, in the lung meetings. I try to make this as visible as possible. And this is the key. Now, I showed you the problem. 27% death in 7 years, 34% death with patients with rheumatology patients. And this is our biggest challenge. 50% of our patients referred initially have a predicted 20% mortality. They have one of these features that make them very high risk, either very poor hemodynamics or very dilated RV or low oxygen consumption or rapid progression. 50% were coming to us in this state. So we need to see the patients early. The center of excellence is not magic. We have to treat the patients at a stage that they're livable. However, alhamdulillah, I would say that our first year mortality rate is only 12% and our 5 years 24%, in spite of all of the challenges you just heard. So females, more than 70%. Young mothers are the victims of this horrible disease. And we have lost too many mothers and have too many orphan children. I'm sorry. Because of late diagnosis. So really it's upon us to make this happen. Now we're very lucky. This country is incredibly fortunate. We have literally every single medication to treat pulmonary hypertension. And some we even got pre-license approval from the DOH. The Department of Health here is extremely supportive and got us the best medications. We had almost 15 years of experience with the top level medications. You need three therapies. There are 3 pathways, and therefore you read 3 pathways. I won't go through all the details. We describe this in the guidelines, but you need at a minimum endothelin antagonist and nitric oxide. So if you only use low-dose sildenafil, you're missing half of the treatment. And in some patients, as they progress, they need the 3rd-line agent. And it does not say anywhere here that you can use monotherapy with sildenafil. It doesn't work. Now we're also very fortunate in the UAE to be the 2nd country in the world, outside of the US and Europe, that has the 4th pathway, which is called sotatercept. And we've started patients in January of this year. We're way ahead of the curve. We're really doing very advanced work. These are the 3 pathways. You need to block all of them. This is like in heart failure. Would you treat a patient without an ACE inhibitor? Would you just give them a diuretic and a beta blocker? It doesn't work. You have to do this to reduce mortality. So as I mentioned, before treatment, monotherapy was the norm. After the center, 90% was the norm, and we need to consistently work on the guidelines. Now, this is another thing that we have that nobody else has. This is called the Linus Pro Pump. This is an implantable device. It's implanted in the abdomen with a tunnel catheter that goes into superior vena cava. So we can give the most potent medication. It's called intravenous treprostinil with no wires, no tubes, no infection. This medication has been shown to reduce mortality since the 1980s. We actually have 8 patients who had this implanted. We didn't do it here. We had to send them abroad. And actually, 1/2 of these patients are expats, funded by charities. This is, again, a very generous country that does a lot of things for the people who live here. So I don't want to give you all the history, but we started in 2015 with our first audit. As a rare disease, the guidelines recommend having a registry. You have to count every single patient. If they miss an appointment, you call them. If they don't come, something is wrong. So you have to keep track. And by doing an audit and registry, we're able to find these patients. This is our first group. And again, this is Dr. Muhammad Badr and my friend Dr. Arif Al-Mullah and a team of pharmacists at SKMC. And then in 2019, we published this in the International PH meeting. And we found this really bad result. So we had these advanced pulmonary hypertension patients who were getting the intravenous or subcutaneous treprostinil. The mortality rate was 40%. 40%. Why? Because they're very sick, referred late. But there were also some actually very bad reasons. Insurance stopped the medication in life-saving patients. And other doctors with no PH expertise stopped the medication, reflecting in mortality. These patients have to be treated at the center of excellence, and we have to fight the insurance if they try to stop their medications. So the American Thoracic Society was our first international publication. This was our 1-year survival, 88% in all comers. And one of the other things that we are extremely, extremely proud of is the ability to support research in this space. So not only do we have registry data that has been published, but we also now are part of phase 4 studies. You know how difficult it is to do randomized clinical studies outside the United States and Europe? We were actually selected as the only site out of the US and Europe to do this study. It's called the phase 4 Restore study. And this is something that puts us on the map as a nation and to take care of a very complex disease. Many other subsequent analyses we've done, looking at patients with lung disease. This is a rare kind of patient. This is interstitial lung disease with connective tissue disease. All of these patients, you'll notice, had a right heart cath. Every one of the patients in the registry has a right heart cath. So we can look at the difference in the treatment, and we can look at the treatment responses. We also work with the rheumatologists. So this is a very large group of rheumatologists in the country. And what we ask them to do is obtain an echo on every patient with systemic sclerosis. Now, only 78% of patients had an echo. But pulmonary hypertension was found in 60% of the patients with connective tissue disease, scleroderma. This is very high frequency and very high yield. So if you see a patient coming from a rheumatologist with a diagnosis of scleroderma, the risk of pulmonary hypertension is extremely high. 60% have pulmonary hypertension. So we're also part of this very large registry. It's called the PVR Meta Registry. There's 27,000 patients. The UAE is contributing 300 of those. So we're actually included in all the papers. This is myself and my friend Dr. Khalid Saleh, who's a pulmonologist at Cleveland Clinic. And we've been included in all of the subsequent analyses and subsequent papers. So one of the things I just want to highlight again, in the guideline, we spent an entire chapter on talking about pulmonary hypertension expert center, what are the requirements, and why do you refer? It is a hemodynamic definition. It is impossible to start treating patients. It is incorrect to treat patients without it. And you're going to ask why? Because you cannot actually measure the wedge by echo. Wedge pressure is an estimate of left ventricular filling, right? What happens if you give a patient with pulmonary hypertension who has high left-sided pressures, vasodilator? They go immediately into pulmonary edema because you have unloaded the right ventricle into the left ventricle, and that's what causes pulmonary edema. Okay? So you really have to avoid this idea. In addition, some of the patients have early stage pulmonary hypertension, and we do exercise. When we do exercise, we see sudden increases of the pulmonary vascular resistance, decrease in cardiac output, and those patients need treatment, even if their pulmonary artery pressure is only mildly elevated at rest. You cannot accurately do this with an echo. So just beware of an echo for treatment. It's a must, it's not optional. And this is since 2015. It's not new, it's been highlighted multiple times. So as I showed you in the other one, pulmonary hypertension right heart cath is the gold standard, not just to measure pressure, precise hemodynamic calculations with breathing, with exercise, with fluid loading to confirm, to support treatment decisions with a complete set of hemodynamic measurements, right? And as Dr. Muhammad very nicely said, it really needs to have the time and effort behind it so you can have a correct, accurate diagnosis. So fast track to PH center, this is the European guideline. This is our guideline. This is UAE. Breathlessness in pulmonary, internal medicine, cardiology clinic, simple investigations. You have a suspicion, we take. We will never deny a patient. If we find it's not pulmonary hypertension, thank you for the referral, take the patient back. That's the only way to solve this problem, because the patients are so late and so misdiagnosed, we can't afford to do so. Focus on right heart cath, again, is in the European guidelines. This is also called vasoreactivity testing. We use inhaled nitric oxide or inhaled alloprost to demonstrate if they respond, they take another kind of treatment entirely. They take high doses of CCV. They don't need vasodilator. That's only 5% of patients. So within the UAE, what's the resource? As far as I know, there are few cath labs that do dedicated right heart cath. And that's why the collaboration and the referral is really important, because it isn't just about doing the cath, it's also about interpreting the results and getting a comprehensive assessment. So as we put the guideline together, and remember there's 46 experts who came up with this idea, an outpatient service in a clinic, emergency care including nuclear scan, dedicated right heart cath, all of the treatments have to be available. Drug therapy is essential, right? So we have to have pharmacists that can dispense it, expert pharmacists, and also if I have an ICU, I have to be able to care for these patients intensive care. So we do bedside PA catheter and Swan-Ganz. Many of you know I do this at the cath lab, and then I send them to the ICU and we give them the treatment for a few days, and then we remove the cath. Now, this doesn't mean we don't need lung transplant, but we don't need lung transplant in multiple centers. Lung and heart transplant can definitely be dedicated in one place, but I believe we need to build more centers. Build more centers means more centers. Should be one in Al Ain, should be a couple in Dubai, should be in Northern Emirates, and we collaborate with our friends in every hospital in order to make sure we can support a building of a center and make sure that they can have the same access as other places. So the essential elements are acceptance. PH Expert Center must accept any PH patient from any other facility on fast track. That's the definition. And we try to overcome insurance barriers and other things to facilitate that. Whether it's 2 in the morning, I get a call from Al Fujairah Hospital, I have a patient with pulmonary hypertension, RV cardiogenic shock, send the patient, right? So we have to facilitate, and we work very hard with our insurance team, even late at night, even on weekends, we try to get these things approved and facilitated. Plus I send the VQ scan and the resources to support the patient. And then the number D is the most important. Parenteral prostacyclin, IV or sub-Q, can only be managed in the center and is very high cost, has a lot of side effects, and has to be titrated. And this is the reason why you have to have all these resources in one place. So thank you for listening to me for the last 40 minutes. I hope if you have a patient with PH, you'll remember, you'll recognize, and you know who to call. Thank you.